Question is going to be on the Green Mile. So again, no wrong answer. Is there a particular character you'd like to primarily focus on?
Percy's an easy one to focus on. I don't know.
Percy?
Yeah.
So what did you see in Percy?
He had what seemed like antisocial personality disorder, just like callous, like lack of empathy or care for others.
So when reviewing and certainly when preparing for your shelf exam, focused on the personality disorders, there's a couple of things I'd like everybody to strongly consider. I know that, and we're going to do this right now, so I'm going to wind up being a hypocrite, but I know that we usually teach these disorders in 3 groups or clusters. That's just the traditional way of reviewing and teaching the personality disorders, and that's fine. But what I would like you to do in addition to that is to take those disorders, put them in a bowl, and then reselect them as being part of 2 groups. Those that do adhere to a cardinal feature, and then those that don't. Because if you look at, and the multitude do, those that adhere to a cardinal feature, all you've got to do is know that cardinal feature. Because then, when you look at your favorite board review text, and you see the diagnostic criteria, they are nothing more than examples of that cardinal feature, and they become much, much easier to remember. Okay? Antisocial personality disorder is going to be yes, cluster B, but in that first column. The cardinal feature of the antisocial personality disorder is a blatant disregard for and violation of others' rights. Every diagnostic criteria that follows are obvious examples of that cardinal sign. Percy included. I don't think anybody here would, I think, defend Percy's behavior as not demonstrating a blatant disregard for and violation of others' rights. If that is the case, and again, we're going to consider this to be normal until it becomes a pattern of pervasive behavior that causes clinically significant distress or impairment in self or others, and it does. Then we begin to think, all right, what questions now we want to elicit, perhaps to Percy himself or others, that will further reinforce or support antisocial personality disorder being our quote-unquote single best answer.
Run with the law.
Run is with the law. Check.
Like the past medical history.
Past medical history. Why do you want to know a past medical history consistent with or significant for conduct disorder?
Because I know the criteria is that you have to have conduct before you turn 18. So like when he was a kid or a teenager, having like the same behaviors, but just at an earlier age.
That's exactly right. Any gut, or I shouldn't say that, any evidence in the Green Mile that provided us that history on Percy? Not me either. I'm taking the pause as no. I mean, if you look at this script, you're not going to find that there's evidence of conduct, cruelty to animals, defiance and oppositional behavior towards authority, destruction of property, fire setting. It's not going to be there. It's just not in the script. So, yes, I think that antisocial personality disorder will be a provisional diagnosis. However, one, you have to agree that has not been supported. So you want to ask, if not Percy, collateral individuals, whether or not there was evidence of conduct prior to the age of 15. Because only then can we diagnose this illness. What if, however, we do get that collateral information? And the answer is no. What are the next 2 steps in evaluating for or trying to understand Percy's antisocial-like behavior?
Look for an underlying medical cause.
Absolutely, all right, absolutely. Because if we were to throw on this diagnostic label, right or wrong, and we found out that he actually had a frontal lobe tumor, shame on us. What happens if the medical workup is negative? What's the next step? I'll give you a hint. It's another form of organicity. I mean, if every time he demonstrated his blatant disregard, he was under the influence of a drug, you know what? Stop the drug. Then let's examine the behavior. Let's evaluate the behavior during a period of sustained sobriety. And only then, and ruling both of those quote-unquote organic causes out, can we say this might be attributable to a mental disorder. However, it would be a mental disorder other than antisocial, since we have conclusive history that there is no evidence of conduct, hypothetically, prior to the age of 15. So let's say we end up here. What now? One last thing before we begin to discuss some clinical terms we may use to describe Percy's behavior. One final thing to do. The other thing is to consider that this behavior might be in the context of a larger mental disorder. If not a medical disorder, and if not due to a substance, maybe another mental disorder, acute mania, acute psychotic disorder, and others that might explain this antisocial-like, these antisocial-like traits. So, routine psychological review of systems, depressed mood, anhedonia, elevated, irritable, or expanded mood, hallucinations, delusions, routine psychopath. What if nothing comes up? Now what? What clinical terms might we consider using describing Percy's behavior? Not diagnostic terms, but clinical terms. Psychopath is the term we're going to probably arrive at, or psychopathy. Psychopathy in this context is nothing more than those very signs and symptoms that describe, if not define, antisocial personality absent the evidence of conduct prior to the age of 15, for which no other cause can explain the patient's behavior. Causes being organic as well as psychiatric. So maybe we have a psychopath here. Any evidence of physical cause, any evidence of substances playing a central role, or a mental disorder for a person?
I think not in the script, but they could exist as characteristics in the world.
Sure, we want to ask more questions, but certainly not in the script. And if, upon further questioning, we don't really find additional information beyond that which the script tells us, maybe this is a psychopath. What other questions do you have about Percy?
What about like an intermittent explosive disorder?
So intermittent explosive disorder is an impulse control disorder. And it's an impulse control disorder that is largely defined, that is, diagnostic criteria, along the context of the actual label itself. That is, there are intermittent and explosive episodes that patients will often describe as coming out of the blue, unsolicited, beyond their control. What are some other disorders similar to this? That is, other disorders contained in that same chapter of impulse control disorders?
Tics.
Not tics. Good. There's two for children and adolescents, or I should say there's two whose onset is usually during childhood or adolescence, and two that are not. So oppositional defiant, the other aforementioned, conduct disorder. What are the two adult onset types? Kleptomania, that impulse or desire to steal. Pyromania, that impulse or desire to set fires. Right. So in total, there's 5 conditions, one being the intermittent explosive disorder. Now, this is per the DSM-5, that is previous to this publication of the DSM, previous to this most recent revision of the DSM. The two childhood onset conditions were in the child onset chapter. Similarly, the title of the chapter itself changed, and I think unfortunately so. The original name for this chapter was the impulse control disorders that were not elsewhere classified, or NEC, which was telling and a perfect reminder for us clinicians. And that is, if the impulsive behavior was in the context of another disorder, you did not diagnose the impulse control disorder. So if the intermittent explosiveness were part of a larger syndrome like psychopathy, you wouldn't make two diagnoses. You would just explain that the psychopathy included episodes of intermittent explosiveness, not elsewhere classified. But to your point, I think it needs to make our formulation, if not an independent diagnosis. Make sense? All right. So again, I think even though the name of the chapter changed and NEC was removed, we still practice the same. That is, if the behavior, whether it's the stealing, whether it's the fire setting, is thought to be part of a larger disorder, we just diagnose that larger disorder. If a person is stealing things that are of no value to them, during and only during manic episodes, we diagnose bipolar 1. We don't diagnose bipolar 1 and kleptomania. All right. Anything else for Percy? What other characters you want to discuss today?
One of the other things with Tom Hanks's character, Paul, the way the story is told is all a flashback. So there could be some, like, you have these John Coffey being a magical, whatever, like he could just be completely delusional and none of this could have happened. You could be saying he's 108 years old, saying this mouse has like magical powers, like, especially how the story's told.
Yeah. So, and this is somewhat spoon-fed to us in this movie, that this is all a recount. And might this recount be a false memory? And so what might be going on in the elderly the elderly Paul, especially when he discloses his age as being 118 years old. So I'm not so sure any of us would be so quick to take that verbatim and take that as a reliable piece of information. So perhaps a delusion. So work this through. Are we quick to say this is delusional disorder, or what would be included in our differential at this point?
Dementia.
Yeah, I think given his age, even though it may not be 118, given his advanced age, I'm thinking of a major neurocognitive disorder with evidence of psychosis. I think psychosis, the incidence of psychosis in dementia is about 40%. So, I mean, this might be a fairly, again, straightforward case study of it. Anything else?
Could be, again, substance-induced.
Oh, it always can be
Yeah.
There's always going to be, I mean, especially advanced age, general medical condition, right? Another medical condition. And if more acute in onset, what might we consider? What do we label cognitive decline that is found to be due to a substance or an underlying medical condition? Yeah, exactly. He could be delirious. And the concern here is that he's reporting a UTI. Now he's reporting it as having happened in 1935, but again, individuals with severe cognitive deficit, perhaps due to dementia, do not always get timeframes firmly established. Right? I'll give you the obvious, albeit not film-related scenario, where someone with advanced dementia will talk about their deceased spouse as if they just spoke with them. How many times have you heard the daughter, the son say, "Mom, Dad's been dead for 10 years." So timeframes are often very disrupted in advanced dementia. So the fact that Paul tells us it was 1935 he had his UTI, we could not discount that a physician just visited him in rounds this morning telling him that it's a urinary tract infection.
If he's not a young guy, would he have any UTI?
Yeah, it's also a little atypical. I don't know if he had if he had nephrolithiasis or, but yeah. It's a good point. So delirium, perhaps delirium on dementia. and then dementia-related psychosis on top of that. Right? So, what else? Now, I had asked this question before to a different class, different context, but it's worth re-asking this. Has anybody here read the novel?
I think I did in high school.
High school. All right, so I'm going to pick you anyway, even though I understand you may not remember. The movie adaptation is different, right? In the novel, and again, this is more, I want to pose this more as a question, but do we know that this is the narrator, or I should say the chapters that relate to the incident of 1935? Does Stephen King take you back to 1935, or is it like the movie where it's narration?
I thought it was told in real time.
Okay.
Yeah.
Because the novel robs us of all this discussion. Because, like most novels, well, they'll tell us what happened in 1935. They won't speculate. The veracity of the report is not in question. Very infrequently is it told as a story in a novel. I mean, The Legend of Sleepy Hollow is a great example of that, right? Where it's told as somebody telling the story, which has all of the people reading Washington Irving's short story wondering whether or not it's true. That's not the case with the Green Mile. So we're going strictly from the movie's interpretation, and therefore allowing us to talk about mental disorders in the cognitive disorder spectrum, dementia, delirium. Other than a UTI, so you're seeing, Paul, every name but Paul. You're seeing Paul, and you have to consider what might be going on here other than urinary tract infection. Not that you don't have your culprit, but you may want to consider other potential etiologies. Question: why would the writer-director have been better supported in having Shakespeare's Macbeth be the movie instead of Top Hat?
The idea of talking to ghosts.
I like that one, yeah. Right, Banquo. Anybody else? Anybody here ever seen or read Macbeth?
It's like the feeling of guilt, where like
Yeah, great parallel there, absolutely.
And then like he still feels the story.
Definitely feels this way. Great pickup. What is the most infamous scene in Shakespeare's Macbeth? Even for those who have not read it or seen any adaptation, you should still know. The most arguably the most infamous scene in all of literature.
Is that the one where somebody gets stabbed through, is occurred or something? Is that, am I thinking of a different Shakespeare thing?
That's it.
That's what I was wondering.
Well, no.
Oh.
It's,
That's the only thing I can
it's an act that follows that.
Oh.
It follows the assassination.
Oh, the well.
The soliloquy?
Which one?
Where the skull? Right? No,
That's him.
Oh, yeah.
I get this too.
Like
Another ghost story.
With a well, I believe.
Not a well.
It's like we wash our hands with water or something like that.
out dam spot.
Say it louder.
Out dam spot.
Who says that?
Reading Macbeth.
Yeah. Right. Arguably the most infamous scene in all of literature. Out damn spot. Again, driven by guilt. In her role in the assassination of King Duncan, it's not only Macbeth, but Lady Macbeth was found to be delirious. Out damn spot. Which is a good thing, because I Heart Lady Macbeth is the acronym to remember all the potential causes of delirium. Right? So, that includes I Heart Lady Macbeth, immunologic. Heart, acute MI. Lady, lumbar puncture. ADG, that's acute hypoxemia. Drugs. And the Y stands for YAWS, Y-A-W-S, which is a spirochete infection, primarily localized to South America. But again, here you're thinking of yaws, syphilis, tertiary syphilis, so RPR. And when you think RPR, please, automatic thought, HIV serology as well, all under one, right? RPR, HIV. Macbeth, malignancy. Ammonia level, rule out hepatic encephalopathy. 3 main C's. Complete blood count for infection. And if you're getting a CBC, always think urinalysis as well. Comprehensive metabolic panel, CMP. And the 3rd C stands for ceruloplasmin, right? Screening test for Wilson's disease. B vitamins, highest yield B12. Lower yield folic acid. Lowest yield B1 or thiamine, especially in someone with no history of alcohol use disorder. EEG. 2 T's, TSH, and trauma, physical trauma, trauma code. H's, head CT or MRI, hypertensive encephalopathy, and the 3rd H is heavy metal poisoning. If an elderly Paul with Elaine were watching Macbeth, this would have been a wonderful look into delirium potentially causing his cognitive deficit. Anything else on Paul?
I'd say like an alternative view is like if we accept that all the events were real, then it could be like PTSD.
Yeah.
Kind of like reliving this experience, he has like these traumas from like maybe like the recollections of dreams. If we like go together, that all of this like is true that happened.
That's right. If this were an experience, and it might not have been just that experience in 1935, but cumulative experiences of having been a prison guard could have resulted in trauma, which itself then serves risk for developing future post-traumatic stress disorder. What would have been, I think, again, Stephen King didn't ask for my permission here. Nobody asked for my opinion, quite frankly, but if the editing were done differently, if this wasn't just a straightforward recount, but instead, with editing, was more intense, it would be more, I think, consistent with what we would feel as a flashback. But other than that editing glitch, yeah, post-traumatic stress disorder.
He's also retelling this, well, this might be going a little bit far beyond, but he's retelling the story from like the protagonist, like he's nice to all the prisoners and everything like that. What if he's also guilty because he maybe was Percy in the story, and now he's like kind of changing the narrative when he's recounting it?
Yeah.
I thought there was maybe like grandiosity. There's a lot of religious imagery like throughout the film, specifically like Christian, which seems to be the tradition he's in. So it could be some sort of transference into like a religious role, especially as he's aging and dying.
Yeah, I want to get back to that as well in a larger context, especially when we begin to talk about John. But yeah, yes, definitely. What was the point you had brought up again?
Was that he's telling the story of like the protagonist and how he's like nice to the prisoners and everything. What if he's Percy and he's changing the narrative, where he's like, that's the guilt that he's...
Right, false memories, right? Maybe confabulation, right? Which is interesting because you're right. I mean, and I think having Tom Hanks cast in this role just plays into that. This is not a perfect character, despite the fact that, boy, does he come off as being as one, right? He definitely comes off being one. Since nobody is, boy, his recount is very selective. What's that about? One of the other students have brought up the fact that maybe this wasn't a UTI, but more of an STD. And if it was an STD, if it did happen in 1935, I think it really opens up a larger pool of questioning here, because we know that he hasn't had sex with his wife in a while, but he has an STD, so how do you resolve that? What is this character, what is this prison guard, this perfect prison guard really doing to that person? So, again, I'm not gonna fill in the blanks for you, but that's gotta be part of the discussion. It would be part of the discussion if you were a clinician and this person did present to you in 1935 with these same signs and symptoms. Anything else for Paul? His delirium resolves. He has a baseline dementia, baseline major neurocognitive disorder. By the way, what differentiates major from mild neurocognitive disorder? No? It's along the lines, but more specific.
Your ADLs, is that?
So that's an example, clinical significance. Right, clinical significance, whether it impacts functioning. Right, and again, this is a major teaching point as well as a clinical pearl, because there's only 2 incidents in psychiatry where a given disorder or syndrome is defined through not being clinically significant. Otherwise, the golden rule is that it is always clinically significant for it to be considered disorder. There's 2 exceptions. One is this condition called mild neurocognitive disorder, which itself is a misnomer. It's called a disorder, but by its very definition, it is not clinically significant, which differentiates it from major neurocognitive disorder. What's the other situation or condition that has this similar differentiation? And I'll give you a hint, it's outside of the cognitive disorder spectrum.
Like obsessive compulsive.
It's not like normal aging, it's not.
Delusional
outside.
disorders?
No, I'm going to give you half a point though. Delusional disorder is a little tricky. The way that vocabulary is stated is that except for the impact of the delusion, other areas of functioning remain intact. But the delusion's impact is clinically significant. So it's a little tricky the way it's worded. So half point. Hypomania. Hypomania looks exactly like mania, right? Dig fast. It's a copy and paste of the exact DSM criteria. The difference is both qualitative and quantitative. Mania must be 7 days, not so for hypomania. Mania, like every other mental disorder, with 2 exceptions, must be clinically significant. The irony is that one of those exceptions is hypomania. Hypomania is clinically insignificant, dig fast. All right. Other characters. The Green Mile.
John Coffey.
Low-hanging fruit. John. So, John presents to you with a chief complaint of everything that we observe in the Green Mile. What is going on here? Doc, I've got this gift. Curse. Thoughts?
He expresses some like hopelessness with the world,
Mhm.
saying how there's like so much bad stuff every day, and like it's like everyone feels it.
And not only that, but I'm taking some liberty here. He's very empathetic, so he really does experience and feel what everything that is wrong with the world. Again, hence his gift/curse. So if we're thinking that this is concerning behavior, we have to think, well, does it appear to be in a mood anxiety spectrum or otherwise a psychotic dissociative spectrum? So if a person comes to you and says, I've got this gift where I can actually take diseases away from other people, albeit it debilitates me and it's killing me. Mood anxiety, psychotic dissociative. Yeah, psychotic dissociative, right? So along those lines, the next step, after you make that commitment, is to choose a single illness, arbitrarily so, from which to work. And in the case of a psychotic dissociative cluster, we should always choose schizophrenia as our starting point, irrespective of patient, irrespective of mood. And always start off with schizophrenia. What are the diagnostic criteria for this condition called schizophrenia? Delusions, there's 4 more. 2 more, oh, sorry, I can count. 3 more.
Negative symptoms.
Negative symptoms, 2 more.
Well, like the timeline?
Not yet.
Okay.
Still 2 more.
Disorganized speech and behavior.
Disorganized or catatonic behavior. Disorganized speech or thought process, right? Disorganized behavior and speech, as well as delusions and hallucinations, all have something in common. That is, they have the pathological presence of something that at baseline should not be there. Hence, they're called positive symptoms. This is a result of increased or excess dopamine in what dopaminergic tract? Mesolimbic, exactly right. On the other hand, the negative symptoms are the direct opposite, right? Direct opposite meaning it's the pathological absence of something that at baseline should be there. And this results from too low a dopamine level. At what level? Which dopamine tract? Mesocortical, exactly right. So think of schizophrenia as a shunt process. It's not that easy, but at least conceptually, where dopamine gets shunted away from the mesocortical, resulting in hypodopaminergic activity, to the mesolimbic, resulting in hyper dopamine activity. Unfortunately, we do not have one medication that corrects the shunt. So the result is when we prescribe a medication that is a dopamine lowering medication, aka antipsychotic, it lowers dopamine at the mesolimbic level, which is the focus, but it further lowers dopamine at the mesocortical level, perhaps worsening negative symptoms, as well as elsewhere, including the nigrostriatal, resulting in additional side effects outside of the periods, specifically EPS, extrapyramidal side effects, including, for the nigrostriatal, movement disorders. Any of that is side effects, observable in, now I'm going back to our original character, Paul. So maybe this is not dementia-related psychosis that's being treated because we're not seeing any of those nigrostriatal side effects. By the way, what is another dopamine tract that may have its dopamine reduced as a result of medication effect and therefore medication side effect? What happens when that happens? What happens when that occurs?
You can get hyperprolactin, too much prolactin secretion, so you might see like gynecomastia.
Exactly right. Okay, so you lose the inhibitory effect of the dopamine having lowered it. The loss of inhibition results in hyperprolactinemia. For women, it's fairly easy to monitor in terms of their loss of the menstrual cycle. For men, it's a little bit more difficult. What is the most common clinical presentation of hyperprolactinemia in males?
So you get breast tissue hyperactivity.
Sexual dysfunction.
More specific. Low libido. Loss of libido, which is why it's incredibly difficult to monitor because we never want to ask that question to our patients. But you have to when you put them in antipsychotics. How would you expect something? People will not ask that, which is why hyperphylectomia often goes undetected in males. Again, not sure how to take that in the context of what we're hearing from Paul, that he hasn't had sex with his wife in a while. Maybe there's a connection there. Back to John. With those 5 criteria for schizophrenia, we need 2 to rule in. Does John rule in? I think this is all gonna boil down to a conversation about one thing, but I'm gonna hand it over to you guys first.
Well, I guess, does he have hallucination? Well, I guess we don't know if he's having like delusions or hallucinations, thinking like he's magical. I don't know if that that's.
I think we'd be safe in, at this point, ruling in a delusion.
Right, but not necessarily.
Right, that's why he presented, right, with this curse that he has.
Right.
Are there two, though?
What about his speech though? Would his speech not qualify as like disorder? It's more just like
Yeah.
truncated and stuff that would.
Yeah, I don't know if it's disorganized,
Yeah.
no. I don't see any tangentiality or circumstantiality, any looseness or flight of ideas. I'm more concerned about his negative symptoms. If we're gonna interpret anything we're seeing as negative symptoms, he would rule in. However, again, I think that's a gray area here. I'm not so sure he has negative symptoms, but if you were to make a case that he does, then he would have the two signs, criteria necessary for diagnosing schizophrenia. I'm just unsure. If not, then we're dealing with someone who's presenting with clinically significant delusions for which schizophrenia doesn't explain it. This gets us to delusional disorder. What specific type of delusional disorder would we consider in John's case?
Isolated delusional disorder,
And that would be?
grandiosity.
Yeah. Yeah. Now again, this depends, because if it's a gift, it's grandiosity. If he really believes he's cursed, it's persecutory. And he, I don't know which one he really believes. That's a conversation we have to have with our patient. Right? Even Paul refers to it as both. So depending on our patient's report, maybe either or maybe we just split the difference and say that it's a mixed delusion. Both grandiose as well as persecutory.
What are the? I always get these like different types of like those. I know you don't like using the clusters, but like the A, B, C clusters, like the personality disorder, like the whimsical thinking, or the I think like schizotypal, or like what would make us lean towards like delusional versus one of those?
Yeah, so looking at the cluster A personality disorders, and by the way, this would be part of the psychiatric evaluation of John Coffey, in as much as we're entertaining schizophrenia as a provisional diagnosis. I mean, a risk factor for developing this condition would be any cluster A personality disorder, including the paranoid personality disorder, schizoid, and schizotypal. The schizotypal personality is defined as an individual who is socially isolated, that is, they're socially and emotionally distant, and have a significant eccentricity of behavior, an oddity. But that eccentricity of behavior falls short of there being a fixed belief that is not reality-based. Because once the individual rules in for that fixed belief that is not based in reality, they are delusional. And therefore, it is not just a personality disorder that is describing or explaining the behavior that is manifest. But instead, a psychotic disorder has to be high in a differential, aka delusional. That's the difference here.
Okay, that's helpful.
People with this condition, say this schizotypal personality, may in fact present delusional under stress. That phenomenon is referred to as stress-induced psychosis. Right? So I want to just give you a little bit of this diathesis here. Right? Nobody in this room has any mental illness. Right? I'm wiping it all clean here. Everybody here is without mental illness. However, in a matter of minutes to hours, I can make each and every one of you psychotic. It's just a matter of which stress I'm going to apply. Trust me, I can. Right? Now, if an individual walked through that door right now with an established mental disorder and sat here, the same applies. But what we know is that the level of stress that would need to induce psychosis in this individual will be less than that experienced by you. That is, any pre-established mental disorder poses risk. So everyone can actually endure or experience stress-induced psychosis, which is just a discussion of what level of stress is required. The individual with schizotypal personality does not require much. Right? So the fact that they may present with a delusion should not automatically result in your saying, oh, you no longer have schizotypal personality disorder or any cluster A personality disorder for that matter. But instead, I like to call this one schizophrenia, delusional disorder, whatever it might be. Instead, what you'll do is you'll carry on with the preliminary diagnosis, the pre-established condition of schizotypal personality, but in your formulation, you'll discuss the dynamic of stress-induced psychosis as explained in your patient's presentation. Okay. Now, once that cause and effect begins to really dissolve and the patient remains delusional, then we could begin to discuss not only the condition of the schizotypal personality, but a secondary diagnosis of a psychotic disorder, whether it be schizophrenia, whether it be delusional disorder, whatever it might be. Questions? So is Paul schizotypal personality that due to incarceration, a fairly significant stressor, is now presenting delusional? Oh no. It depends on what Paul, quote unquote, looked like prior to his incarceration. And whether we get it from the patient self-report or other collaterals, that might clear some of this up. That might actually tease away that question. What if we did contact, or let's say Paul doesn't tell us, and we did contact someone who knows him quite well. And let's say that person happens to be from Wales. What might else you consider? I know this is coming from left field, but I want to end with this point.
Are we talking about John Coffey or
I'm
Paul?
sorry, I keep on. Paul Coffey is a former Edmonton Oiler, and that hockey player has confused this movie for me for decades now. Right? It's John Coffey, right?
So he knows someone else?
Very close.
And that
Mother,
person's
father,
from
brother,
Wales?
sister from Wales. This is me trying to pick your brain, see if anybody did the deep dive here.
And what was the question again? If we got in touch with someone?
Yeah, because we're deciding what's going on here. Might there be a pre-existing condition, specifically something like a schizotypal personality disorder, that now is presenting delusional because of stress-induced psychosis incident to his becoming or being incarcerated. So we reach out to a collateral, close family member who's still in Wales. And they provide us information that I think is going to blow this all up. And the hint is in Skeleton Key, and the hint is in this morning's episode of Seinfeld.
Lead poisoning?
Lead poisoning, not lead poisoning. Anybody here investigate or review the myth or the mythos of the sin eater? John? John Coffey is a sin eater. It's a culturally sanctioned belief, largely localized to Wales. It's true if he believes it. Nothing further to do. Whether it's a curse, whether it's a gift, to him it's real. This is a culturally sanctioned belief. That's origins appear to be in Wales. Now, I don't know if John's parents, ancestors are truly from Wales, but that's where it appears that this particular belief had originated. The idea here is that there's a person, usually in villages, that has this gift, that after funerals visits families, and usually over a very ritualistic meal containing bread. The bread absorbing the sins of the individual allow a clean and cleansed soul to reach the gates of heaven. Upon eating the bread, the individual is exonerated from all their sins. Unfortunately, the sin eater becomes sick due to their gift or curse. That's what John has. And that's real to him, if he believes it. So we would kind of, I think, redact any medical record documentation of a psychotic illness here. Now, it may still be causing clinically significant distress or impairment, we would not ignore that. But we would be very careful on these diagnostic labels and diagnoses right now. So we might end up right where we started, assuming everything here, at least from the perspective of John, to be within normal limits. Questions? Comments on John or any other characters in the Green Mile? No, we're good. All right, we'll end it here. I have not yet determined, I'm out on Friday, I'm out next week. I have not yet determined whether or not we'll have something at noon. If so, we'll get it up on Twitter sometime soon, definitely